So I chose the next speaker for the most controversial topic we have. So I'm going to be very objective. I'm going to walk down the middle here as best as I can. Anybody see Root Cause? The documentary came out a couple years ago. Raise your hand if you saw it. What'd you think? I'm indifferent about it. They made some points that were valid, and then maybe some other points maybe were a little exaggerated. But there was a couple comments that were made in this movie, and I'm going to try to get them verbatim. One was 98% of women with breast cancer have a root canal tooth on the same side as the tumor. That's one comment that was made. And then another one from a very respected cardiologist who I know said that root canals and heart attacks or heart disease are not correlation, it's cause and effect. So these were two very damning statements, and I'm just going to start with that, and we'll go from there. I don't want to say his name. Thanks, Mark. Okay, first of all, we have to define what a root canal is, right? Because we use that term for everything. Oh, root canals are bad. Oh, he's got a root canal. Root canal. Root canal, there's the root canal. There's root canal treatment. There's root canal infection, root canal failure. So we have to be careful how we talk because we tend to say that to our patients as well. So you guys can read this. This is our goal was always to save teeth, right? And really still should be. But you have to weigh the costs versus the problems with it. So this is what we did, right? We would just go in there, and instead of extracting them, we would do the best we could to get everything out of the actual tooth. And that's what we did. And we said it was sterilized because we would use sodium hypochlorite or other medicaments in the process as well. And this is what a root canal was, root canal treatment at the time. So this is the problem, which we all know, right? And in fact, most of you probably know this, about 35% of the actual root canal system is never even touched in a normal root canal with normal rotary instruments, hand instruments. 35% is not even touched. So if somebody makes the argument you never get it fully clean, they're right if you do it that way. And I'm going to offer some other options later on, but let's at least all agree on that. So 3 facts and 1 supposition, if you will. Okay, root canals do not render teeth sterile. We know about the 3 miles of tubules, but they're filled with everything, every microbe that you can possibly imagine. They've been associated with all kinds of systemic problems. And when I say that, I mean there's actual studies that you can find in peer-reviewed journals, well-done studies to show this. So it's not just some people saying this. The last thing is a supposition. We've all had this, I'm sure. Some patients said, oh my God, after I got the tooth out, everything went away. I'm healthy now. This is wonderful. So if you're a dentist who sees that more than once, maybe a few times, you start to think, wow, these are bad. So if I get these out, all of a sudden I'm fixing all kinds of systemic issues. You may be right. So this little simplistic drawing I like, it's an it's an Oriental medicine doctor in Florida, and even he is saying that, he says about half, I think is what it says there, half of the root canal is not even touched, so you leave all these bugs in the bottom of the tooth. And so a very simplistic drawing, but we're seeing this more and more in your mainstream publications as well. So it's not just so, if you don't have a patient yet that's come to you and said, hey, I've read about root canals, I heard, I don't want to get that, surely everybody in this room has heard that at least once, right? So, in my practice, what I always did, no matter how I felt, was I always let them make the choice, right? You inform them, you tell them, this is what I know if you do it this way, this is what I know if you have the tooth out, I'm here to support you either way, let me know how I can help. And that's it, right? Keep your confirmation bias to yourself when it comes to this. So it's simple, right? Look at that. Look at that. I don't think we ever saw this in dental school. Yet, despite the complexity of these canal systems, many of us in this room, probably all of us, except for the very young graduates, because you don't do root canals, which is good, we got resolution of infection, right? We could see it on x-rays. We got pain relief. So despite being so complex and knowing there's no way we got it all clean, we still had some success, depending on how you define it. Does anybody know the real reason why so many root canals fail? And they'll get a prize. Damn, these are all good answers, but I'm looking for something really simple. What'd you say? You're close. Untrained dentists doing them. General dentists. They don't know how to do root canals. They think they do. We do. They don't. Now that one's actually pretty well done if you want to, again, I'm going to try to walk right down the middle, so just bear with me here.
I've seen them fail from specialists.
Oh, absolutely. For sure. But why? I just told you why, right? Okay. But this is the reason why so many. Okay, look, we've all seen these, right? I mean, I don't know, this looks like an old, probably thermophil coming out there, and sealer shot out the apex, and at least he found the lateral canal, so it's pretty impressive. Okay, look at the majesty of the tooth. Sorry, I got excited on this part. It's just gorgeous. Look at the dental tubules. And by the way, look right up here. You can see why there's so many carious and mechanical exposures, because those beautiful little tubules go right up into the enamel further than we even actually realize. So, we see these simple drawings here, right, where we've got our primary dentin, our secondary dentin, and then our pulp. And there's probably a thin layer of tertiary dentin in there. But it's much, much more complex than even this little micrograph shows. Okay, what's the problem? All of these things. Probably the one that we don't think about as much is biofilm formation. Biofilm is what? It's a bunch of species of bacteria all colonizing together to form this film that is 1,000 times more resistant to any kind of antibiotic than simple planktonic bacteria, like the kind you might isolate on like an auger plate. 1,000 times more resistant. Nothing's going to get to it. So that's so what most endodontists or dentists who do root canals will tell you is, well, that's why I use sodium hypochlorite, or I use whatever, right, ozonated water, because that's going to kill everything off. Yeah, if you can get to every single part of that canal, maybe. But that's the big reason. So, of course, there's a poor immune response and all these organisms that learn what's going on, and they just can resist anything you throw at them. So, what you guys probably don't know, or I know endodontists don't know, is most of these articles that you'll find are in the Journal of Endodontics or some kind of endodontic journal. So they're literally telling all their practitioners all these problems. More than half the teeth studied had periodontitis, had bacteria in the tubules all the way to the CEJ. Almost all the species that were isolated were obligate anaerobes, the bad ones, if you will. 4 of 10 specimens with apical periodontitis were heavily invaded by yeast. Diflucan's not going to work on that. More. All these are endodontic journals, except for this last one here. But look, they're basically saying that we know this, right? I mean, all the pathogens tested were able to penetrate into the tubules, some further than others. And look at this last one here. These guys are teaming up, right? Interspecies interaction facilitates colonization. They're all joining forces here. So it's pretty hard to assume that we can get everything clean. This one, I believe, I was trying to find one a little bit more recent for you here. This is 2019, yeah? So look what they're saying, a real simple statement, right? The main cause of endodontic failure is the persistence of microorganisms that cause intraradicular from within the root canal system or extraradicular from the periodontal tissues and become resistant to disinfection measures. So this study basically was telling us that it's the microbiology is the problem. It's the bugs. And they were saying Enterococcus faecalis is the main culprit, right? That's when we hear E. faecalis or faecalis. But there was also Fusobacterium nucleatum, the most predominant microbe in our mouth. There was Propinobacterium. There was many other species. So to me, this was not such a great awakening, but it is a recent article, so I want to show you that. I do this for every talk each year, and that number grows. So this was I did this a week ago on PubMed. So you just type in root canal failures, and that's how many results I had. So that's how many scientific studies are talking about root canal failures as of a week ago. This is a cool study that was done, and I'd call it a case study, and I'll explain why in a second, by a member in our academy in 2012, and it was a neat study. He had 25 extracted teeth that had root canals. The cool thing that he doesn't say in the study, I don't think, but I knew because he was from Texas with me, was that at that time we had just PAs. I don't think there was any cone beam in 2012, or if there was, nobody had it. And he sent these 25 radiographs to a bunch of us dentists and said, "Tell me what you think about the root canal." and they all looked pretty solid. Like it looked like I had a good ligament, the bone looked good. Again, these are just two-dimensional x-rays. So he liked that. Here I'm picking these teeth. They were extracted for whatever reason the patient asked for it or whatever. And he was looking at how do the root fragments react with enzymes that are critical for life. And these were 6 commercially available enzymes, so you could test them to the root fragments. And he was seeing how much did they inhibit the enzymatic activity. So you can see on the chart, there's all 25 teeth, and that was the level. The average was 65.6% inhibition. So that's considered severe reaction, right? So this was these root fragments tested against the enzymes. They inhibited their activity. Bad. So why do I call this a case study and not a traditional real study? What's missing? Controls. Exactly. Now, you would argue, well, how are they going to do that, Griffin? Pull healthy teeth from the same mouth? I agree. I'm just saying that you have to have controls because there's bacteria in our mouths anyway. So I'd want to see what happened when you just took a healthy tooth from the same mouth, or a different mouth for that matter. Still a great study, and it was published. It was nice. So this is our status report back in 2001. Obviously, microorganisms can persist after endodontic treatment. Cytotoxic chemicals, i.e. sodium hypochlorite, used in endo can enter the general circulation. You guys know that sodium hypochlorite, if you go through the apex, that can be really detrimental. I mean, you can burn things, you can kill off fibroblasts, all kinds of stuff. So it's not the best medicament to use if you're cleaning out the canals. More work is being done. This is the key that we even said, this is 21 years ago. More work is being done to evaluate whether calcium oxide filling materials or any other technique can eliminate the potential for systemic health effects of endotherapy. I added in this little thing about Endozlase by Val Cantor. Does everybody know who Val Cantor is? Not members already. New people know who Val Cantor is? She's an endodontist in California. She joined as a member a few years ago, and when she joined, she didn't realize that we were completely bashing her whole profession. Not me. Some people were bashing the whole profession, and she came in and she, to her credit, she is working diligently on figuring out ways to do this right. And I mean get a tooth sterile, clean, completely clean, body happy, sound ligament, good bone, no systemic issues following it. So we're talking amazing studies going on. I'm going to share with you, she's given me permission to show you some of the stuff she's doing. But when you start talking about partial root canals where you can go into the pulp chamber, clean out just some of it and do certain medications and things and not do the whole removal of the whole process, and they heal and everything's great. Some really cool stuff she's working on. It's very detailed though, so I don't want to share too much of what she's doing because I don't understand it all. Okay, does everybody know the term cavitation? Yeah, just a dead spot. It's just like a dead bone is what it is. Interestingly enough, if somebody tells you that cavitations is sort of a trendy word in the biologic world, or it's not trendy. It's been around since 1915 when G.V. Black described it. So there's that name again. But whether or not it's overdiagnosed or underdiagnosed, that's left up to you to decide that as a practitioner. But you pull out a tooth and you can get all kinds of more loss of bone. That could have just been a sloppy extraction. I just wanted to show a photo showing how much the bone can be deteriorated in that area. Okay? So this is our statement on endo. Each patient must be evaluated on an individual basis, considering the patient's medical status and other factors. Simple sentence. Again, it's your way of treating them as an individual and saying, here's what I see, here are your options, how do you want to proceed? So, anybody that knows me, I have to throw this in on every talk, no matter what we're talking about. I love ozone. And I mention it because, one, it's part of Dr. Cantor's process, but two, just because there's a lot of studies as well, mostly in endodontic journals. So this is one here where they're talking about, this is actually 2004. So this is going way back here. And look what they're saying here. They're saying that after irrigating with ozonated water, they were comparing ozonated water to other things like distilled water and sodium hypochlorite. The viability of E. faecalis, which I mentioned earlier, and S. mutans significantly decreased. Now look at the second sentence though. Remember I mentioned this just a second ago, that they're saying that there were problems when treating with the sodium hypochlorite, that you actually kill off fibroblast activity. So, and that makes up what? Collagen, our extracellular matrix, this important stuff here. So that was 2004, I believe. This one here is talking about gas, 2013. This is out of Croatia. They basically looked at about 37 root canals from like 25 different teeth, and they were testing them here to see how the gas affected. And you can see this here on the screen that, look at this. So 82%, 67% of aerobic, 93% of anaerobic bacteria. So the average was 82%. So this is like, and by the way, they used a very, very low concentration. So we're going to show you that you can use, Bob Harris, our last speaker, will get into this in more detail, but I just wanted to show you guys that there's been plenty of studies on this. This, I believe, is gas and water, if I'm not mistaken here. So this is 2013. It's the Journal of International Oral Health, and he'll get into this in detail, I'm sure. But look at this low amount here. So first they did the water, it was great, and then they did intracanal gas, a fluoride. That's a very low amount of ozone, and a pretty low volume as well. And it showed encouraging results because they were using too low. A little higher, the results are amazing. All right, I think we have time. So I mentioned Dr. Canner. She's the endodontist out of California. We have a little podcast in this academy called Word of Mouth. We don't do it on a regular basis, but every couple of meetings we'll interview somebody that just spoke, and we'll do a little podcast, and usually it comes out about a year later. But this is 3 minutes of an interview. I know. This is from 2019, by the way. But I'm interviewing Val Cantor, and I just try to get, because she has so much to say. She's fascinating to listen to, but I try to just get down to 3 minutes and really just pay attention to her, because the interview is annoying. If I can get on here. And I'm not even kidding. So let's go a little bit further with the root canal infections. Okay. Because I have plenty of patients who will come in and they say, oh, this tooth's killing me. We'll do an x-ray or a 3D scan, and sure enough, we'll see an abscess. Mm-hmm. Whether I can't tell if it's acute or if it's chronic, we go through their symptomology and all that, as always. Touch on a bit about not only working with a specialist who's trained, has the right equipment, that's critical, but also catching something early enough, and maybe you doing what's called vital pulp therapy versus a full-blown root canal. Can you differentiate between those for us?
Yeah, absolutely. So there's a slow process that happens when you have decay. There's some sort of disruption in your ecosystem, in your mouth, in your body. So you end up with a cavity or maybe a cracked tooth because your teeth aren't moving together properly. Maybe your teeth are crowded and they're not sliding around properly. You're not able to chew your food, or you're grinding. There's all these reasons why the nerve can start to get damaged. If the nerve is damaged to the extent that it's reversible, we have options like vital pulp therapy. So with vital pulp therapy, we can go in, we can clean out the problem, we can kind of monitor that crack, bond it together in a way to restore the tooth. And we have advanced technology like lasers and gentle wave technology, which can remove the irritated or the infected part of the pulp or the nerve, but sometimes you can actually save the part that's below, and that's what I'm so passionate about.
So you're actually avoiding doing a full root canal,
exactly.
Right?
It's like a partial root canal, or you call it a vital root canal. These are procedures that have been around for a long time, but because of the new technology that we have, we can do them in a way where we can almost sterilize the inside of the tooth, and the body can take care of the rest. Right. And then we have biomaterials like bioceramics and PRF, platelet-rich fibrin, and when you put all of these things together, you can create this magic little sandwich in the tooth. And underneath, as you saw as I presented earlier, yes, from Dr. Randy Garland in Southern California, beautiful case with the gentle wave, where he was able to use that, remove the infected part of the tooth, yeah, then put PRF down, yeah, yeah, then put the bioceramic, and the tooth stayed alive. It came back to life. It created new tooth structure. It used its own stem cells to grow new tooth structure, and that tooth stayed vital. We love that. But right now, the safest, most effective way of treating these infections is using advanced technology like laser activated irrigation, yeah, which is basically a generic term for PIPS, photon-induced photoacoustic streaming. It's been around for a decade, but just not a lot of people know about it, not a lot of people understand it. And what it's able to do is it's able to clean these areas in the tooth that we've never been able to clean before. So when we talk about root canals being, having still some bacteria in there, we know that it's been a struggle to get all of it out. These are complex anatomical structures deep inside the tooth, and we're working through through a hole a couple millimeters big. It's incredible what endodontists do and general dentists, but it's important that you have a microscope. That's the only way you can see down these teeth. So if you're having a procedure, you need to have a practitioner with a microscope with high power magnification or loops, and those loops better look really long, okay? Because there's different variations, and you really need to be able to see down the canal.
Here yet? No, Bill's not here yet. So he's going to talk on microscopy, I think next. So he's going to get into that. So she seems excited about what she does, doesn't she? It's pretty good. That's who I want to be my practitioner. So I show that because, again, we started off with the bad, and I hope this is maybe somewhat good to avoid the ugly. So whether or not you do root canals or how you feel about them, I don't know that really matters, again, when it comes to treating patients, because that's your confirmation bias, no matter what it is. You need to work with them, listen to them, learn their health history, and then let them make the decision. You can help coach, obviously, but I think it's real important, and that's why I love this academy, is that, we allow this conversation to happen. Because some people would think, well, then you're not a true biologic dentist if you even talk about root canals. Well, maybe that's true, but I was just always under the impression that I wanted to let the patient make the choice. And, it's a big decision sometimes, and you can sit there right now and say, well, that's just stupid, because we know root canals, you can't get them clean, and you're hurting the patient. Maybe. I don't know. We have to do everything on an individual basis and let the patient make that choice. So on that note, let's get rid of that. So this is what she's working on. She calls it ozone laser. It's clever. And this is what I wrote, that it's a biologic root canal therapy. I think it's the closest thing to doing a biologically sound root canal. And, I go into detail on this when I teach ozone, but for now, just know that she uses the Lightwalker laser. That's the Photona Lightwalker laser. Ozone. She does a lot of supplementation pre and post-op. Obviously, she's an excellent clinician, so her instrumentation's incredible, and a very thorough obturation technique. So what's new besides what you guys were taught? Well, ozone is probably a new thing. The laser being used now. This is not like the old lasers that you could put inside a tooth and it had the straight line effect, and you would say, I'm getting down the canals, like a guy did in Texas almost 20 years ago and said he was getting it clean with this laser. That's not true. But this type of laser is one that you actually put your tip inside the pulp chamber with some kind of solution. I would say ozonated water, but whatever. And with the PIPS technique that she mentioned, she said it really fast, the photon, acoustic, photo streaming. It's now called sweeps, which I think is shock wave enhanced photoacoustic streaming, whatever. It's the coolest pulse of laser light action that brings everything. So you can just sit there and put it in the chamber, and you watch all this stuff just come out of the canals for like several minutes, just junk. It's unreal. So it's different than trying to put a laser down each canal. It's just a very different process. Got a couple more very short videos just to show you a little bit more of what I'm talking about. This is one where she's just doing ozone gas. Okay, you'll see a lot of bubbles and stuff happening. She's not putting liquid in the canal, okay? That's just what's coming out of these canals. And by the way, that's just part of her process. This is not the end, obviously.
B2. Come out and then B2.
Yes. Ah, neat.
I don't know if we
Now this next video I'm going to show you is, now this guy's voice is a little bit louder, so it'll be good, but he is basically showing both this PIPS, now called sweeps in action, so you get to see what I was talking about, excuse me. But then at the end, he's going to also show you the obturation technique. And what I want you to notice is where he's putting his actual filler material and where it's coming out of. And it'll be very obvious. You don't have to guess at all here.
Here's a case, just again showing some more pips. We're going to show you more videos of pips itself. Upper left molar, again, using the pips tip that we have for the power lays, placing the tip into just the orifice, cleaning out the mesial buccal 2, and watching the material flow out of the mesial buccal 1. And you can see the entire chamber, everything's moving in the chamber. When we've done this before on clear teeth, we actually are in one canal and can see photoacoustic action of the streaming in other canals while we're not even close to those canals. I used to joke with Rico that maybe we're doing root canals on the entire arch if we're doing just one tooth with pips because it's so powerful. Again, I'm just going to show this video very quickly. This was one of the first teeth I ever did that I saw these anastomoses, filling the mesial buccal canal of a lower molar and watching it come up the mesial lingual of a lower first molar. And then it had the same phenomena happen in the distal canal. And it just blew me away the first time I saw this. I just was astounded by it because I had never really experienced that with all the flushing and with conventional methods. And when I started to utilize the laser and pips, I've seen this. This is routine now. I mean, if I don't get this, I'm a little bit worried that I haven't got the system cleaned out properly. And notice I don't say root canal, I say system, because it's a system. And I want to clean that out totally in 3 dimensions. Again, here's a lower canal, 5 canal molar. There's 3 mesial canals here. This is a lower first molar. This is not a wisdom tooth. And I'm filling 1 canal, and I'm 3-dimensionally obturating all the canals at the same time.
What he's showing in the system is that it is truly a system, that everything's sort of connected, and it, our assumption that we had a canal here and a canal here and a canal here was all separate is really not true. And there's so many, of course, accessory canals and everything else that I showed you earlier that it's really a very challenging procedure for sure. So back to cavitation again now. Before I do that, any questions on the root canal part? Because I don't want to just skip over something like that. That's pretty important, but I wanted to show you, again, the good and the bad and the promising. Questions, comments, anything? Okay, good. Cavitation, so again, essentially dead bone. But here's a little description of it. So when you take out a tooth, right, you got to get the PDL out, as well as even a little bit of the bone if you want to really do it right. So you can take out a tooth successfully, never clean out the ligament or bone, they'll heal, and oftentimes down the road you'll notice on an x-ray, preferably a cone beam, and I'll explain that in a second, that the bone is actually, it never filled in, or it's dark, it's dead looking. That is what a cavitation is. Okay, there's a little picture there. You can see the bone drawing looks pretty good. Lunch was an hour or so ago, so we're good. It's gross. So cavitations, I can tell you just in my experience, 29 years of practice, I rarely saw painful ones. Now that's Nico, which we'll talk about in a second. But so cavitations are either diagnosed because the patient read about them, heard about them, and is asking you to investigate, or you do that as part of your exam. And if you do, it's got to be a cone beam. I mean, that's sort of the gold standard. I mean, we saw some films from Ingo earlier where you look at a 2-dimensional x-ray and you don't see anything. And what's really sad though, as we're now, like, I'm excited for all the young dentists who are being taught that immediately. Think about us older guys that we have a patient saying, I'm telling you, doc, this tooth is still hurting. And we take our 2-dimensional x-ray and say, there's nothing there. I'm telling you, it's solid. I'm telling you, 6 months later, this thing hurts. Nothing there. And now I realize that all those years that we were saying there was nothing there, there was something going on. We just couldn't see it. So we were doing the best we could with the technology we had, but now you guys got everything. There's no reason why you can't be just a great diagnostician. This is a picture from Joe Palmer. Also remember, these are basically just 2 failed root canals. He flapped and you could see, wow, they're really failed. So these would be true cavitations. And when you see something like this, I mean, you guys probably don't realize that besides having microbes there, which we know, I mean, they also have outgassing issues and other things that join the whole party there, and it's a mess. I mean, it becomes pretty toxic in there. So question comes up then, how do we treat it? I don't like to cut, never did, so you would see me probably doing more stuff like this where we put a little X-tip port in there and we're squirting ozone gas or whatever else that you want to. It's a whole different lecture. But something like that, ozone gas is not going to fix that. I mean, that's a huge hole in the bone there. So anybody here treat besides our members, anybody treat cavitations in here that are new to this meeting? No? Have you seen them? Yes? You seen them? On an x-ray or actually like that when you flap? Both. So what did you think at the time when you saw it? Just
weird. Kind of nasty. It also doesn't exist. So that was weird.
yeah, right? I mean, and that's the issue. And you have to even be careful when you're writing down your notes, how you call it and things. You don't want to use the term cavitation, you know. So anyway, for some people, this is a very, very real thing and a very harmful thing. And there have been plenty of doctors in this academy who have treated many patients and had great success with lots of issues. So I don't want to downplay that at all. That's a very important thing. So Nico, that's the painful one. Again, I don't know that I ever saw this in 3 decades. I know a lot of docs here in this group have. That is a case, though, that I wanted to show you where this was another lecture that I gave where a patient had a little pain where a tooth had been extracted years prior. This doctor did like to cut and went in there and did the surgery, and it was much smaller. The hole was real tiny. And 6 months later, she's no better. So she goes back, and so they open up again, and they cut the hole even bigger. And she still wasn't well. So we did months and months and months of ozone treatment, and it actually filled in with bone, and she was out of pain. So it's kind of a neat little fix to something that started off very aggressively, and we became less aggressive and got really good results. But you guys can read that there. It's the neuralgia, the pain-inducing cavitational bone death, painful cavitation, cell-by-cell death. These are some causes of NICO. Obviously, trauma, toxic dental materials, and then there's predisposing factors, as always, for anything here. So you can read those: blood clotting disorders, chemo, radiation, bone dysplasia, atmospheric pressure changes, age, thyroid dysfunction, lupus, sickle cell, anemia, gout, and physical inactivity, just to mention a few. And then the risk factors that we see with a lot of things. Okay, this is another name. These names, by the way, I think can be interchanged a bit. They are different things technically, but they're all basically the same thing, which is dead bone. Okay, so we can call it jawbone osteonecrosis. Again, this is one, if you read that first part, it says it doesn't cause pain. Those are the ones that I saw. They were painless. They didn't even know they had them most of the time. But then if you look down the third sentence there, it says a typical patient has pain for about 6 years. It should say may have pain for a certain number of years, okay? Because it's not always going to be painful. It occurs more frequently in middle-aged women in the third molar region. Makes sense, right? That's where a wisdom tooth might have been pulled, not cleaned out properly. Now we got dead bone. You guys know what bisphosphonates are, right? They're overly prescribed by oncologists, but I get it, mostly for some kind of a cancer that's got, mets. So they're like, I got to stop this. We have to build new bone. So they prescribe bisphosphonates like Fosamax or Actonel, or Reclass is the one that you inject once a year, I think. The problem is that if you look in the literature right now, and I'll give you the exact number, I think they say for IV bisphosphonates, the chance of a person forming jawbone osteonecrosis is 0.88 to 3% IV. So to me, that's still a high number, but for oral, which is a lot of them like Fosamax, they say it's like 0.01 to 0.03. So basically nobody. And I can just tell you that's not true. I mean, I saw many patients who were just diagnosed with cancer. They got on the bisphosphonates, and 2 weeks later they had it in their mouth. Lots of them. So I think those numbers, I don't know where they're getting them, but those are the numbers that justify an oncologist saying, I have no problem prescribing this to you. Okay? If you're a dentist that at all is going to attract these kinds of patients, because you will once you're in our world, people will actually seek you out. You need to know about this. So you need to know about bisphosphonates. You need to know that it contribute. At that point, it's called bronze because it's bisphosphonate-related osteonecrosis of the jaw, and it's a very important thing. It's way more prevalent than you realize. This was a case, and this is a case study that I did, and when I first did this, I took all the credit because I thought I was a stud. But I now realize I need to thank Bob Harris, because my partner in business, who referred this patient to me. And I say that because he must have done something, because I did at least 10 more of these cases and didn't get the same result. But let me walk you through this. So Bob Harris is seeing this patient over in the Indiana, Kentucky area, and she was on Fosamax for 10 plus years. She had a lot of other comorbidities, but had really bad bronch. And so she was moving to Texas. I was in Austin. She moved to Dallas, which is a 3-hour drive. And he said, can you see her? And I said, yeah, I'd love to see her. And he said, and don't charge her. She doesn't have a whole lot of money, and this has been going on for a while. I said, no problem. She came down, and I said, look, I'm going to need to see you every week for these injections I want to do. I can't do that. I go, I got to see you every week, otherwise it's not going to work. She goes, I can come once a month. It's just too far. And I'm like, once a month? I said, okay, I'll do the best I can. I said, but please do me a favor. So this was the scan before. You can see the bone is trying to break off and slough. This is the lower right, because I'm in a mirror. So you can just see it looks like it's not that big, but it's right there by this first molar area. So I said to her, look, I'm going to inject ozone gas. So that's the lesion there. You can see I've got a needle going right there. There's the lesion there. Look where it's bubbling out over here. So I knew that this thing was probably this big, because I'm injecting on the posterior side of it, and anteriorly you're seeing all this pus come up. So I saw her 1 month, let's just call it October. She came in November. It was looking a little bit more obvious. I did it again. December, I think, was one more time, and then she walked in, I think, in January with that in her hand. And that is 13 millimeters this way, and I think it was about 18 or 19 that way. But look at that. So now why this is exciting to me is because there's nothing in the literature where they only treat it with ozone gas only. There's plenty of things with antibiotics and some other adjunctive things, including ozone. You never want to correct it surgically. That makes it worse because that's trauma. So it's basically palliative treatment only. How can I make you feel better? You've got this until you stop doing the bisphosphonates or whatever's going on. It's going to look like this, yes.
What's your gamma and how many cc's?
25 to 30 gamma. She's asking the amount, micrograms per milliliter, or gamma is what we say. And honestly, 12 cc's, I think 3 in each. I sort of surrounded. I went posterior, anterior, supra, and infra. And honestly, I made up that number. I mean, because Bob and I have been talking, and now we teach ozone and all that, but I was like, let me just squirt some in there. I did ask her, you can't do anything else. If you want to drink ozonated water, that's fine. But nothing else. Nothing. Because if I'm going to publish this, I need it to be true to what I'm saying. So my point again was that I did this 10 more times on at least 10 other people, and I didn't get the same results. So I know Bob, he's probably going to be very modest, but he must have done a lot of neat prep work ahead of me, probably involving much of the same thing. But it was a neat study, and you can see on the scan that it is gone, and it's going to start, and that point now, to my knowledge, has actually rounded off. So it's kind of a neat case, and the tissue looks beautiful. So, okay. How do we detect all these things, right? As I mentioned, they rarely show up on PAs. So cone beam. Does everybody here either have a cone beam or have access to a cone beam? If you don't, you really should. It's a game changer. I got it because I wanted to be able to confidently tell a patient if they truly had a cavitation or if they had a failing root canal. So you can do a cone beam on someone who has 6 root canals, let's say, and 4 of them are probably going to have dark spots or something. 2 of them might look great. And you scan through the whole thing, so it's 3 dimensions. You're looking at everything. So to me, it's a nice, confident way to say to somebody, these 2 look like they're, for whatever reason, doing okay. What would you like to do? These other 4 look bad. What do you want to do? At least you're diagnosing it. So I'm not a huge fan. You guys know what Hounsfield units are? Hounsfield units are the way that we measure to see the density of bone. So a lot of guys that's what these numbers represent. So they'll say, oh my goodness, this has got to be a cavitation, or that's got to be because of the number. But as you guys saw on a previous slide, the bone is extremely cancellous, right? Porous. So I never really relied on that. I was more like, can I see it? Can I actually see, and can they see it? Because if you sit them down in a room and you teach somebody and show them how to read films, they are your patient for life, especially if they came from someone who didn't do that. Education is everything. So, but you can see them, they're very, very obvious. And at that point then, again, most people will say, well, I don't have any issues, so what do I do? And you just have a discussion about options, right? So, a little bit more on it here. So you can look at root canals in 3 dimensions. You can look for these bony lesions or cavitations. You can see things like files that are inside teeth. You can even see cracks in roots. I mean, I've seen some of those. It's amazing. Obviously, if there's impacted teeth they didn't even know about. I mean, you can see everything. Downside to this, there is a downside. You are responsible at that moment for 10 years on whatever you got on that scan. So I started off with the Galileos. Anybody have the Galileos? It scanned the whole thing, right, Ingo? And I was so proud I could see everything. Yeah, Griffin, now you're responsible for everything on that scan for 10 years. So if something happens down the road, well, why didn't Dr. Cole find that? He had a scan 8 years ago. He should have been able to see it. Can we see the scan and see that there's not a hint of it there? So you can now take sections, which is kind of nice. You can get little tiny sections of an area you're looking at if you just want to focus on one area and protect yourself, okay? All right. I want to leave a little time for questions. We got like 10 minutes because hopefully there's some. Anybody have any questions? Yeah. No. So that's a great question. Most towns will have somebody like a radiologist who works with either CareStream or whoever that you can pay to look at it. That's a smart idea. If you're like, look, I want to have complete, protection, I'm going to pay this radiologist to look at and do it myself. I, like Ingo said, and kind of I was a geek about that, so I like learning about it, so I would hire them, come for half a day, show me how to read these things, and then if I was scared and maybe wasn't sure about something, then I might hire them for that one particular case. But you can get pretty good at reading them. I mean, you start to see what's normal, architecture of the bone and what is not. And you don't have to necessarily diagnose it. You can just say, this is a dark area, suspicious area in the bone, patient, obsta, whatever. Yeah, it's a good question.
Do they actually come to your office?
Who?
You said when you hired them.
Well, in Austin, we did. She was very good that way, but most don't. No, most they'll say, send me the scan, let me look at it, I'll diagnose what's on it, and I'll send it back to you for X amount of dollars.
And then thank you, to sort of piggyback there, if you are hiring someone, from my understanding, when it comes to cavitations, they're not exactly acknowledged as dentistry as a whole, right? ADA and all. So if you're hiring someone to take a look at that for you,
Yeah.
they don't recognize it, what do you do then?
Well, but they will always tell you what they see as an anomaly. So yeah, so it's their job to say, I don't know what this is, but in the lower left quadrant where number 17 used to be, there is a very lucent area. Could be, and they might give you a differential. I don't know. Could be mieloblastoma, could be this, whatever. That's just your way of at least getting a professional to look at it, right? Because again, you got to be careful, right? I mean, you bring up a good point. What if it isn't a mieloblastoma? Do you treat it the same? I mean, you need to be on the ball with that. So that's why I think I was also the guy that didn't like to cut, because I didn't want to sever a nerve. I didn't want to do it improperly. I didn't want to, who knows? But we have plenty of members here that are very good at it, and they would say, forget Griffin, come to me. Yeah. What do you need? Okay, I'll keep going. They'll at least identify an anomaly, right? Something. Were you raising your hand, Dave, or just stretching? Or, Mike, yes. So I would do a follow-up scan, a cone beam scan, and I don't want to get into too many details, but I did like a 5-week treatment where I would inject the same spot once a week for 5 weeks. And the amount, if you were going to ask that question, I do the test, I call it feedback. So if I'm injecting from a syringe of ozone gas into a hole and it's just sucking it up, I just keep going. But eventually your plunger comes back and you can't get any more, and that's where I end it. And I would, of course, measure it. I did 12 cc's today. I did 8 cc, whatever. And then I would wait 5 more months after that, Mike. So it was kind of a 6-month process. And I would do a cone beam, and I would make sure, remember, I taught them how to read the actual scan. I would do apples to apples, because we can play with those scans, right? Well, look at this. So I would show them, notice how the teeth are shaped right here on this one. Notice how I matched it up exactly on this one. Does that make sense? When you're doing a scan, you can roll through. So I teach them to be able to look at how do the teeth look on either side or in front of it, and make sure that I'm matching up apples to apples. So that's what I did. So if you're asking if I did blood work or anything like that, no.